specifics about him and his training. He joined Illinois Cancer Care in 1994, and prior to that, he received his undergraduate degree from the College of Holy Cross in Worcester, Massachusetts, and his medical degree from Tufts University in Boston. He also completed his internship and residency in internal medicine at St. Vincent Hospital in Worcester. Been there. Worcester, Massachusetts. He completed a fellowship in medical oncology at the National Cancer Institute in Bethesda, Maryland. And in 2002, and many of you that are his patients will remember this, he completed a fellowship in neuro-oncology at Duke University. And again, he specializes in brain, colon, and skin cancers. And again, we welcome him to the podium. He's going to talk to you a little bit about brain tumors. And again, you have your little note cards. Feel free to write down any questions about really any type of cancer. I'm sure he can handle whatever you've got for him. So join me in welcoming Dr. Geoffroy.
Good afternoon.
Can you hear me without this?
No.
So I'm going to talk to you a little bit about one of my personal favorite things to treat, which are the brain tumors. And so I have the privilege of treating all of them out of the office in Peoria. And because we have Dr. Andrew Sung in Peoria, who trained at MD Anderson for brain cancer and brain tumor surgery, we get a lot of referrals from the general area, Quad Cities and LaSalle, Peru, down around Springfield. So we get to see a lot of people from a wide range of areas. But of course, Janet did tell you to write down questions about most anything, and I should do the best I can to answer them. Does this show up okay? So here we go. So there are many kinds of brain tumors, and we don't have anywhere enough time to talk about all of them. So I'm just going to touch some very basic points that are important when we treat brain cancers and brain tumors. And altogether, it's only 1.5% of all the cancers. So, lung cancer, 200,000 cases a year, breast cancer, over 200,000, prostate, probably, 350? We're somewhere in the 75 to 80,000 range. But they're very important, and there are quite a few varieties. And so you never see 100,000 of any of them. You get to see a few of many of them. But they are important. And there's some very important basic points that we have to remember. Number one is, if you have known anyone with cancer, or if you yourself have had cancer, you don't have stages for brain cancers and tumors. No stage 1, 2, 3, or 4. For the most part, they don't go anywhere. They stay in your head. And most of the time, they stay pretty local in your head. So I don't have to worry about livers and lungs and stuff like that, because they don't do that. They just stay in your head. And that's a big difference between brain tumors and a lot of and other cancers. And the second thing that's important is that surgery, except for the malignant lesions in the brain, is almost never complete. So you do surgery to find out what's going on, and you do surgery to get rid of most of it, but it's really, really hard to get rid of all of it. And why? Because these, as a rule, when they grow, they're like little roots. They're like your oak tree in the yard growing into your water pipes and your water system, your septic system. And it's just infiltrating between the dirt, which is the brain. And you can't get it all because you can't keep cutting pieces out of your brain. Different parts of your brain have very important functions, and you just can't keep taking them out, because if you do that, then the patient will have too many deficits. They'll be missing too many important things that the brain is supposed to do that they cannot do. And when you do that, you will not do well. So surgery, there are limitations. Number one is they infiltrate, and number two is you have to try to keep the normal brain function as intact as possible. So it's very challenging for the surgeon. But we do talk about surgery in three basic things. or extensive resection. So the first one is what we like, which is a gross total resection. So if I have an MRI and I do surgery and I look at it afterwards and they say, you know, you got 95%, that's a gross total resection. That's really good. Now I gotta tell you, even when the MRI says, boy, it looks like you got it all, I know he didn't get it all. There's always there are a few cells that are still left in at the very least. But we do know that a big surgery, a gross total resection, is better than anything less than that. That's what we aim for. A subtotal is if you can't take out more than 90%, take out 60%, 50%. That's good. Sometimes the location is so bad next to the brainstem that all you can do is a biopsy. And that's the toughest of the toughest. And those are usually spots that are in just very tough locations that are very important. And those are the most challenging patients. Because when you can take a lot of the cancer out, you relieve a lot of the pressure. When you can only do a biopsy, you relieve none of the pressure. So the goal of the surgeon is to take out as much as you can safely without causing a loss of function. Now, there are some parts of the brain that are a little more silent, like the frontal part. In the front of the front, we can do great surgeries because if you take stuff out there, patients don't notice it and their function is essentially normal. There are other areas, for example, in the left temple, you have a speech area right here. And if you take that out, then those people will have a difficult time saying what's on their mind. They know what they want to say. This is the connection that allows them to actually say it. And so if you ask them, well, what's the stain on my collar from lunch? They won't be able to tell me it's a stain. They'll call it something different, a pencil. They can't name a watch. They can't think of your name. We call it an expressive aphasia. So again, the anatomy of the brain and the functions are very important. There's this thing that is extremely important that we refer to as the Karnofsky performance test. There's a different version called the ECOG. Both of them tell the doctor how well can this patient function on a day-to-day basis. And every research trial has a certain cutoff level for this. And if you are below that level, you cannot go on the research trial. Because we know that if you are not functioning well at home, that the treatment is really going to be rough on you. And we know that you will not do well because you're going to have a lot of side effects and far, far less benefit. This Karnofsky comes up all the time. It's very important. And just as examples, again, the Karnofsky runs on a scale of 0 to 100. So 100% is somebody who has a cancer, no symptoms whatsoever. They can do anything they want. They can work, they can play soccer, baseball, jump out of an airplane, go on vacation, no symptoms. Once you get to 70%, that's the point at which a person is affected to the extent that they can't go to work on a regular basis anymore. The cancer is dragging them down and they can't work. They can care for themselves, they can feed themselves, but they can't work. Most research protocols, that's the cutoff. If you are 70 or above, you go on a research trial. If you're less than that, and again, the reason is that research has a couple of important points, one of which is do not harm the patient. You are trying to find better treatments. What you don't want to do is to harm the patient. It's always important for a cancer doctor. And sometimes it's easier done than others. Sometimes you have good intentions and it doesn't always work out the way you like it to. You strive for that. So the 100% is no symptoms. The 70% is you can't work any longer, but you can pretty much do regular stuff and care for yourself. For example, 40% is the point at which somebody is disabled where they need significant assistance from family members, nurses, or whatever. And I still use this for treating everybody else as best as I can. So this Karnofsky is extremely important, both for research and for general treatments. Let's get back to brain tumors. So of the brain cancers, there are about 26,000 a year in this country. That's a rough estimate. Compare that, there are over 200,000 times in this country that cancer will go into the brain. The lung does it about 100,000 times a year. Breast cancer does it commonly. Melanoma does it commonly. Kidney cancer does it commonly. So if you have a spot, if an individual has a cancer in the brain area, it's actually far, far more likely that it came from somewhere else than it started in the brain. And that's an important point. And then there are about 50,000 other kinds of brain tumors. Meningiomas are pretty common, and actually they have a very different biology. You have tumors on the pituitary, and tumors in the middle ear called schwannomas, which cause ringing in the ears and deafness. But the one we're going to focus on are the actual primary brain cancers. And these are a few of the kinds of categories, and they all have very weird, very old names. And actually some of these descriptions are becoming a little less important because there has been a lot in the last 12 weeks about new things I have to know about how to treat these people. And I'm going to get that a little bit later. But you may hear the word astrocytoma. That's a very common one. There's something called an oligodendroglioma, and sometimes you'll have a mixture. It'll be a mutt. It'll be a little bit of each. In some other things, ependymomas, gangliomas, DNETs, it goes on and on. Somebody asked me a question early about a medulloblastoma. That's a common brain cancer in kids. Because kids have brain tumors and cancers, they're a lot different than adults. They behave a lot differently, and the treatment is a lot differently. But we refer to them as PNETs, and if they are above a certain level, they're called supratectoral, which is above that level, and if they are below the level, they're infratectoral. You don't have to worry about remembering that. But for kids, we call them medulloblastomas. I have about 3 adults with that. And then there are lymphomas of the brain. And then meningioma I threw in there. That's actually one of the more common ones. Technically, it's a benign tumor, but I will argue that anything that grows in your brain that is not supposed to be there is not as benign as you can get out of it. Why do people get these? Good question. We do know that radiation given to your head to treat a condition, whether it's lymphoma or brain cancer or brain tumor, 20, 30, 40 years down the road, whatever part of the brain got radiation is at increased risk for a bunch of other kinds of things, because that kind of radiation causes cancer and causes tumors. And there are some hereditary factors, but they make up a minority. 1.5% maybe they factor in. For most people, if they ask, Doc, why did I get this? You do not know. So they're not very common tumors and cancers, so it's a little harder to find out why. There's a reason, we just don't know what the reason is. Which kind of is frustrating. It's not tobacco, it's not diet, it's not lifestyle. Some of the hereditary factors, there are two conditions that are related. Neurofibromatosis, there's a type 1 and type 2. I actually have a patient with type 1. So they have these lesions beneath the skin. And this patient I have, her mom has several neurofibromas. You can just see when she comes in with her daughter. And the daughter has what's called a glioma. And it's right in the middle, which is classic for neurofibromatosis. So you're not born with this, but you're born with a predisposition to develop these kind of things. You're much more likely to have it. The second type of neurofibromatosis is actually far less common. And they have the benign tumors in the middle ear, and they'll come in because they can't hear very well. And you find out that they have this little boo-boo that's wrapped around in the 8th nerve and affects their hearing in the middle ear. There's also something called Turcotte Syndrome. Now, on the table in the research department, on the very end, there's information about what's called the Lynch syndrome. Well, Turcotte Syndrome is the association of colon cancer with brain tumors. There are also some bone abnormalities. And there are 2 varieties. One is called HNPCC, which is Hereditary Nonpolyposis Colorectal Cancer. Those are people who have colon cancer younger than the average age, which is about 65, so they'll have it younger than that. It runs in the family. They make a lot of polyps. Not thousands of polyps, but many more than the average person. It's also known as Lynch syndrome. That's one variety. And then the second variety is what's called familial adenous polyposis. These people make thousands and thousands of polyps. Their colon looks like shag carpet from the 1970s. Pretty amazing condition, much less common. And that is associated with medulloblastoma, which is actually a very common kid brain tumor, not so much adults. But the fat get colon cancer. I saw a 19-year-old with colon cancer. The average age is 64. So that's, again, it was hereditary. And there's something called leaf-framania, which is very rare for brain tumors. But they have muscle bone cancers, sarcomas, and they have breast cancer, and they have brain tumors. But that's, it's reported in probably fewer than 100 cases in the world. So hereditary, once in a great while. I've got one patient for sure that I have that has neurofibromatosis. But it's uncommon. Again, for most people, I don't know why it's So now we're going to lump things together a little bit, although I must tell you that in the last 12 weeks, this is probably going to change a little bit. But the astrocytomas, which is the most common group of primary brain cancers, again, we don't have stages, I have 4 grades. Grade 1, 2, 3, and 4. Grade 1 is kids. I think 3 months is the youngest I saw do. And it behaves very different. So I don't see this, I don't see kids up here, I just see adults. I see grade 2s, 3s, and 4s, and they give them their own special name, which is not so important to remember. And by the way, if you are looking this up on the computer, they report them as the WHO grade 1 and WHO grade 2. And that's the World Health Organization. So these are pathologists who specialize in brain lesions, and there are also some in breast, who get together once in a while, and they all agree what is new and should we change how we look at these things. It's just FYI, that's what that means. It's not the rock and roll band from the 70s. I like it. The second type are the oligodendrogliomas, and they are less common. They only come in grade 2s and 3s. You don't have 1s, you don't have 4s, 2s, and 3s. And then they have what are called the mixed tumors, which is the mutts. They are half and half. They're really not half and half, they can be 80 and 20, but they have features of both. Again, in the last few weeks, this is actually going to be a little less important than it used to be because things are changing. And in 5 years, I don't know that we're going to be looking at things like this. I think we're going to be looking at molecular characteristics. We're not going to look at the outside of what I look like. We're going to look at the inside, what's going on in here. But for practical purposes, we use all that information, and then we lump into low grade, grade 2, and high grades, 3s and 4s. And again, in addition to whether he said it's astrocytoma, in addition to whether they say it's a grade 2 or grade 3, there are some very important molecular characteristics. And also, I love the cytogenetic characteristics. I'll explain that in a bit. So this is the heart of the beast, and this is probably more important than what it looks like under the microscope. And this is what's new in the last few weeks. So sometimes mutations are bad. What's a mutation? In cells, there is information called the DNA, and it's the code, like an encyclopedia collection, that tells a cell how to behave. And when things become cancerous, it's because there has been damage to this information, and it's not read properly. There can be extra information, there can be information that's lost, duplicated, all kinds of things can happen. Sometimes the mutations are good, sometimes mutations are bad. With brain cancers, there is one that's very important. It's called the IDH1/2. And it's part of this thing called the Krebs cycle, which is biochemistry from way back in medical school. And about 7 out of 10, grade 2, will have this mutation. And it's a good thing to have. And this affects how we treat people. And this also affects how well things can go. It's very important. This actually may be something that happens really early in the cell going from normal to tumor to cancer. And it may drive how the cell develops on that line. So it's maybe a very early change. But it's a good thing to have. The second one is getting back to DNA. We know that a fair amount of, especially these oligotumors, if you look at some of the DNA information, these chromosomes, you're going to find out that number 1 chromosome got chopped off, and number 19 got chopped off. And this is very important for how I treat the people. In fact, some of the research trials that we have depend on this very feature, and if you are positive, you cannot go on the research trial, and if you are negative, yes, you can go on the research trial. So it even directs how I'm treating patients on research trials. And again, this is another thing that you say, wow, this chromosome is messed up. It's a good thing. It makes them behave better. It makes them behave way better. It's an enormous difference. And the final one is also important, but it is a bit more restricted. This is more for the what's called the glioblastoma. This is for the most common, most aggressive brain cancer in adults. This is what Senator Kennedy had. He actually had surgery at Duke, and he got his chemotherapy radiation up in Boston somewhere, I think Mass General or something. But there's a special gene, and it comes in two ways. It comes what's called methylated, that's a really good thing to be, and it also comes unmethylated, and that's the not so good variety. This is actually, it repairs damage, is what this stuff does, inside the bad cell. And when it's methylated, it's shut off. So the cell can't fix the damage that we're causing in the treatment. But when it's not methylated, the cell can fix the damage, and that's why it's so important. And on research trials for glioblastomas, you have to measure this in everybody, because it makes a big difference how things are going to work out. So how do we treat these people? So we will put all the grade 2s together, whether it's an astro or an auto or a mixed one. And what we do first is they're going to see the surgeon. And if they are under the age of 40, and if the surgeon does a great surgery, he does a gross total, he gets rid of more than 90%, and the patient's doing well, and the tumor was not very large to begin with, we don't need to do anything else. And some of those people go 10 years, and nothing's going to happen. And maybe in 10 years it'll start to grow again in the same place. And maybe you can do another very good surgery, and you may spare them chemotherapy, and you may spare them radiation therapy, and it'll be very productive and live a very nice life. But if they're older, and I disagree with this age cutoff because I'm way over this age, but 40 is old for this condition. If they are over age 40, or they have adverse factors, the big one being the surgeon was not able to get 90% or better. There's a recent publication, well, it's not published yet actually, it's an abstract. So we have heard the information, it's protocol 9802. It's from the radiation people. And Dr. Buckner at Mayo talked about it and gave us some information about it. And we don't have the details. But what they did, they took people who were high risk, which is over the age of 40, who did not have a great surgery, and they said, okay, you're all going to get radiation, and half you guys are going to get chemotherapy, the other half you're not going to get chemotherapy. And what happened was that they found that the people who got the chemotherapy lived on average 5.5 years longer than the people who only had the radiation. Now, 5.5 years longer survival for almost any cancer I can talk to you about is huge. I mean, they get excited when it's 3, 4, 5 months longer survival. Just 5.5 years. Now, what I don't know about this, and what I cannot wait to get, is the characterization about the IDH1. That's very important. And the 1P to 19. I don't know that yet. It's not published. I also don't know the characteristics of which ones were oligos and the other stuff. And another recent publication made a very big deal out of that, and we're going to get that shortly. So this came out a few weeks ago. This is what's called a practice change. This is going to change what I do for people. There are a lot more people going to be treated than used to, because this says we're going to help you a lot. 5.5 years, which is pretty big. For the grade 3 people, again, you take the surgery, the surgeon does the best surgery possible. If this special chromosome thing is normal, it's not affected, and they're high risk, we have a special research trial for them, right, through our office. It's called the CATNON trial, or RTOG0834. So you get one of 4 possibilities. You all have your best surgery, and then you all get radiation. And some people have only radiation. And some people get radiation plus they get chemo, a pill. And some people get radiation and then chemo. And the final people get radiation and chemo and then more chemotherapy. And it's to find out how much that's going to help. And so we try to put everybody who qualifies on that trial. But again, you have to be, the 119 have to be normal. They cannot be affected, because that treatment is different. So if you're a grade 3 and you have a good surgery and you are affected co-deleted, which is a good thing, then you get radiation, you get a different kind of chemotherapy, And this was published about 2 years ago. It was a big deal because it took them 17 years before they were able to publish results. And if you look at the people who were treated with radiation in this chemotherapy who are in the best category, at 17 years, more than half are still living with a brain cancer, which is pretty amazing. But they have good characteristics, which is this IDH1, this 119, is huge stuff, because it tells you how well you're going to do. The worst of the worst, the grade 4s, the glioblastoma, the most common one. Do the best surgery possible, so again, all these people have surgeries. And then, if you are under the age of 70 and your Karnofsky is over 70%, so you're a good category, Dr. Stoops in 2005 published the results of a radiation treatment that took these people to surgery, and they all had a radiation, and half got chemo pills called Temodar, and the other half did not. And he said that, you know what, you get radiation in Temodar, you live longer than if you only get radiation. And so in 2005 that was published, and that is how these people are treated. And that actually has not changed, except we may do 12 cycles of chemo instead of 6 in the old days, but that's about it. And again, this one has been pushing 9 years now. We haven't made a whole lot of progress since then. But your survival improved on this one by about 3.5 months average, which is not great. Remember this energy methylation thing? It's a big deal. When he went back and he looked at the people, he said, well, who did well? The people who did well were the people who had this NGMT when it was in a good way, methylate, which means the repair thing was shut down. Those people did much better. In fact, if you look at the people, whether they get chemotherapy or not, if this thing is active, it doesn't seem to make a difference. It only makes a difference if it's shut down. So this is important for me to know because perhaps I can spare somebody getting a chemotherapy that isn't particularly helpful. If a person is over the age of 70, they didn't allow anybody over the age of 70 on that original research trial. If somebody is 71 and in good shape, I'll treat him pretty much like they were 69 or 70. I'm not going to make that. But, we see patients who are 85, in their late 70s. How best to treat them? Honestly, it's not known. You have to use your judgment. If there's a research trial, it's good to put them on that one, although we don't have many available for that age category. Some people will argue that if this special gene is active, it's good, just give them some chemotherapy pills. And if it's not good, just give them radiation therapy. But honestly, the research has not told us how best to treat these people. And that's the importance of research. If it comes back, the standard is this drug called Avastin or bevacizumab, special antibody. And then you can use the pills in a different dose. That's helpful as well. I don't cure anybody with these kinds of tumors. We extend their survival and hopefully we extend the quality of their life. But they're not curable. And the final little group are the lymphomas of the brain. Now, lymphomas can spread into the brain, and the higher grade ones will do that. But these actually start in the brain. Now, you don't have any lymph glands in your brain, so you can ask yourself how this happened, but it does. And they're usually the B cells, very common. And you still got to check them out, so they do have to have their special PET scans and the bone marrows and all that good stuff. And you have to, the eye doctor has to look in their eyes because some of those people, the lymphoma will actually start in the eye and spread to the brain. So you got to check that out because the dose of the chemotherapy is different if it starts in the eye. So it's a very standard, it's called a slit lamp. Your optometrist does that every time you go see it. And what the best treatment? Well, we're not really sure, but the Sloan Kettering people published the treatment in November of last year. And what it does is it gives you a few chemotherapy medications, and there's one drug called methotrexate, and that is the backbone of that treatment. And they follow that up with a bit of radiation therapy, and actually had very nice results. And so that's a treatment I can follow. Surgery for this lymphoma is only good to make a diagnosis. It has no value in terms of taking out 90% or 60%. Give me enough stuff that I know what's going on and get out. Because the drugs are going to kill the lymphoma, not the surgery. So it's very good. Again, the backbone of the treatment is this methotrexate stuff, also a little bit of radiation. It's a bit of a complicated treatment, has been in the hospital, but it's quite good. And that's all I got for you.
Do we have any questions? We have question cards? Anybody? Okay. We have someone great at this table willing to turn one. Anybody else have any cards? Questions? Thank you.
I spent a whole year doing just this stuff.
Start off with these two.
So the first question is about the Genomic Health Research Center and predicting the recurrence of ductal carcinoma in situ. So I don't do tons of breast cancer. A couple things about ductal carcinoma in situ, or DCIS. A couple new things about that. Something about the margins. The ability to cure ductal carcinoma in situ is in the high 90% range, because technically it's precancerous. Has not yet acquired the ability to spread. So pure ductal carcinoma in situ should be curable almost every time. And the only concern is if you don't get it all, you can have a recurrence within the breast, but it should not recur to your lungs or your liver or anything like that, because you can't do that, it's precancerous. So the big deal for this one is getting it out of the breast area. The question is whether it is overdiagnosed or not. And there's actually a lot in the news lately because of a large research trial from Canada about the value of mammogram, of which there is a huge disagreement between the Americans and the Canadians who published it, is the value of the mammogram. But again, ductal carcinoma in situ, as a rule, the cure rate should be high 90%. And I think you tend to have issues only if you don't follow up afterwards, because it can degenerate and become an invasive cancer with time. So if you leave some stuff behind, you could have a recurrence. Having said that, you could take all the DCIS out and have a person who's predisposed to cancer for genetic or other reasons, and they could develop another cancer that is actually a real cancer next time, an invasive cancer, and then the cure rate would depend on the size and the estrogen receptor status, the HER2 status, the lymph node status, and other characteristics. Will I ever be cancer-free? So for the brain people, usually the answer is no. But sometimes it just stays dormant for a really long time. You know, when we talk about stages, we say stage 1, stage 2, 3, 4 for regular cancers. And when a cancer comes back, all it says is that we were wrong. It wasn't a stage 1 in the breast, it was a stage 4, and there were a few spots in the liver, but the scans didn't show them. And if you have a lung cancer that you take out and say, well, it was in the first set of lymph glands and in the lung, and it was a stage 2, and then 2 years later it's in the bones or in the liver or in the brain, and you were wrong. There were some spots floating around, and your test didn't find them. And so, well, how can that happen? That's because we have x-rays and MRIs and bone scans, PET scans, and all kinds of fancy stuff, but there is a level of bad cells that can be present in your body, and every test can detect a certain amount of cancer if it is there. But if there is less than that certain amount, then we can't see it. And so the problem with the stages is that it uses the best technology that we have, but that is far from perfect. I don't think we'll ever have a test that's 100%, because cells are much too small for that. So hopefully, yes. Well, for my brain patients, my primary brain patients, they're not cancer-free. How do you decide if a patient will have chemo intravenously by taking a pill? That actually is usually a characteristic of the actual medication. So some medications, like all our antibodies, if you take them by mouth, you'll probably digest them, you won't absorb them, and so you will not have any benefit whatsoever. So if a medication can be absorbed by mouth and can give you good levels in your blood, you can take it by mouth. And if it cannot, then you have to have intravenous. A few of them, like 5-FU is intravenous, you can't take it by mouth, but there's a pro-drug called capecitabine, there's a Loda, and that one you take by mouth. My great-granddaughter was affected from surgery, has facial, speech, walking issues, affected her left side. Will they get better? So if it is from a bleeding issue after surgery, the answer is it can get better. If it is from swelling from the surgery, the answer is it almost always gets better. If it is caused by removing parts of whatever process was in the head that eliminated the area that controls those functions, then there's a chance that it will not get back to normal. Sometimes they will sacrifice certain nerves. And so it depends on the reason that the loss of dysfunction was, for example. So kind of what I talked about early on is your speech and ear, if you take that out, then more than likely for the rest of your life, you're going to have issues with naming things. And, you may call a watch a clock, or you may call a pencil a pen, and those things don't typically get better. And that's why, again, it's important for the surgeon to be very careful when they do the operation to try to avoid taking that stuff out, because if you actually lose the brain tissue itself, as a rule, you don't get all that function back. But if it's from bleeding sometimes, or just swelling, the swelling part gets better. But usually find that out pretty quick.
Any more cards? A bashful group. Anything else you'd like to add?
Thanks for coming.
Thank you very much, Dr. Geoffroy. And again, just a couple closing comments. We want to thank you so much for joining us this afternoon. We hope that you have found this to be helpful. We will all stick around, Dr. Geoffroy, and the staff will stick around until the last person is gone, because we're here for you and we want to answer any additional questions that you might have. I would just remind you, if you would just take a few minutes and fill out the evaluation form that we have at your tables, and that will really help us as we move forward in developing other programs. And again, thank you for your time and for your support and for being with us this afternoon. Have a great evening.